Hello everyone, my name is Dr. Ashraf and today we're going to do headache and what are the important causes of headache. So this is the mnemonic that I use. It's called Spin Them Kong. This is what I've made, but you can use any mnemonic or anything that can help you. So S is for stroke, subdural hematoma, subarachnoid hemorrhage, P is for pheochromocytoma, I is for infections, meningitis, encephalitis. N is not a cause, but it is there just to rule out any neuroscreen like weakness, numbness, tingling, loss of sensation, any dysphagia, any slurring of speech. T is for TIA and also to rule out any trauma, tension, and also other headaches like migraine, cluster, and T is also for temporal arthritis. H is for hypertensive emergency, E is for ENT causes like sinusitis, and M is medications like NSAIDs. There's some OCPs that can cause headache. So C is for carbon monoxide poisoning, and again I've put N here for neuro weakness, numbness, and loss of sensation, and G is for glaucoma that can also cause headache. Okay, so starting with our number one cause, that is subarachnoid hemorrhage, how your patient is going to present to you. They will present with sudden severe headache, and they can state it as the worst headache of their life. They can have loss of consciousness, nausea, vomiting, photophobia. These are like severe symptoms that are associated with subarachnoid hemorrhage, that are seizures. They can have like hemiparesis, weakness, numbness, loss of sensation. So that's why the N is there. I know I have put it twice, so you have to make sure that you do your neuroscreen. Certain risk factors that are associated with subarachnoid hemorrhage are hypertension, cocaine use. There can be aneurysm that can rupture and then spontaneous, or it could be spontaneous or it could be traumatic, like especially after a fall. When you examine a patient of subarachnoid hemorrhage, you can find nuchal rigidity, papilledema, Kernig's, and Brudzinski signs. So very hard to differentiate it from meningitis. So what investigations you're going to perform here? You're going to perform a CT head, and you have to mention it non-contrast. You can see hyperdense blood in the subarachnoid spaces. So whenever the examiner asks you what kind of investigations you're going to perform on this patient, or what is one investigation you're going to perform on this patient, so you have to mention CT head, non-contrast. If CT is negative and still you're suspicious, then you can order a lumbar puncture for your patient, cerebral angiography, MRA, CTR, CTA angiography is also, there are also other investigations that you can perform, but especially neurology and neurosurgery ask us for these investigation. Um, and emerge, we especially start with CT head. These are the routine investigations that we are also going to ask. That is CBC, electrolytes, coagulation profile, ECG. So these are all the routine investigations that we are going to perform. This is how the CT head non-contrast will look like. There we can see hyperdense blood in the subarachnoid spaces. You can see blood in the basal cisterns. Um, Interventricular hemorrhages can be seen. The brain would be edematous. Um, so this is again, like, that's not very important, delayed ischemia or infarction, but if the examiner hand over a CD head to you. So instead of saying that you can appreciate this as a subarachnoid hemorrhage, you can give them findings that, you can see hyperdense blood in the subarachnoid space, or you can observe some interventricular hemorrhage there, and you think that this is a CT scan of a patient who's having subarachnoid hemorrhage, or this confirms subarachnoid hemorrhage. Okay, this is a closer look. You can see hyperdense blood, and then interventricular hemorrhage, and the brain looks the edematous. Okay, so what is the treatment? So initial management is you have to admit this patient, you have to make this patient NPO, elevate their head, check their neurovitals every 1 hourly. You have to consult neurosurgery, so that if it's, for example, if it's an aneurysm, they can go ahead with clipping, control the blood pressure. So these are the systolic blood pressure. So 120, 150 would be your upper limit. And then if you're suspecting vasospasm, then you can start with a calcium channel blocker like nimodipine. For seizure prophylaxis, you can give levetiracetam, and for ICP management, for intracranial pressure management, you will elevate the head, but you can also give mannitol and hypertonic saline to the patient. If this patient is on a blood thinner, then you have to stop the anticoagulant for this patient. Thank you so much for watching this video, and I hope this was helpful for you. Thank you.